Good evening, my dear friends and colleagues. Ramadan Kareem for everyone. Our topic will be about membranous glomerulonephritis. It will be divided into two parts, part one and part two. In part one, we will talk about introduction, epidemiology, etiology, and pathogenesis, clinical manifestations, and pathology. In part two, we will discuss in details, especially the KDIGO modifications, KDIGO 2020, which has major modifications in the management of membranous glomerulonephritis. We will talk about diagnosis, natural history and prognosis, and treatment. Introduction contains the most important notes that you should know about membranous nephropathy. The first one is that membranous glomerulonephritis is considered an immune complex disease. The pathogenesis is mainly immune complex deposition. Immune deposits in the form of mainly IgG and complement are deposited in the subepithelial surface. The most important note is that membranous is an immune complex with deposition of immunoglobulin G, IgG, and complement in the subepithelial surface. That will lead to podocyte injury, increasing glomerular permeability to plasma proteins, leading to heavy proteinuria in most of the cases and nephrotic syndrome. As all glomerulonephritis, it might be primary or idiopathic. Membranous can be primary or idiopathic or secondary. And we cannot define patient as having primary or idiopathic only after exclusion of the known secondary causes, which will be discussed later. Again, membranous glomerulonephritis is considered immune complex disease mediated or autoimmune diseases. Primary membranous or idiopathic membranous accounts for about 75 to 80% of all cases of membranous. From all cases of membranous, primary is about 80% of cases and secondary is about only 20% of the cases. Again, we should exclude the presence of any secondary cause. Membranous is the most common cause, very important note, is the most common cause of nephrotic syndrome in older white adult. The most common cause of nephrotic in white adult. This is an important note because the most common cause of nephrotic in blacks is focal segmental. The most common cause in young adult and older adult white, especially whites, is membranous glomerulonephritis. What about secondary causes? Secondary represent about 20 to 25% of cases of membranous, and we will talk about it later. All the secondary causes will be discussed. What is meant by membranous? From its name, membrane. It is referred to thickening of glomerular basement membrane. There is thickening from its name, membranous, thickening of glomerular capillary wall. That is, which is evident in light microscopy. It's clear evident on light microscopy. What about the immune fluorescence? Immune fluorescence, as we described before, that membranous is an immune complex deposition disease. There is immunoglobulin G and complement deposition. They are deposited, immune deposit IgG and complement, in the form of, an important note, fine granular deposition. Don't forget this term. The pattern of deposition, and we will discuss it later, the pattern of deposition is fine granular in immune fluorescence. In electron microscopy, the dense deposits, which are the immune complexes, are present in the subepithelial surface. Very characteristic. To conclude, in light microscopy, there is thickening of glomerular basement membrane. In immune fluorescence, there is immune deposits, which pattern fine and granular. In electron microscopy, there is dense deposits in the subepithelial surface. It's very important to know. What about the etiology? Membranous can occur at any age in all ethnic groups. It is much more common in men. Is a rare cause of nephrotic in children, because the most common cause of nephrotic in children is minimal change. Minimal change representing about 80% or more than 80% of cases, followed by focal segmental. Membranous is not a common cause from the start, is not a common cause of nephrotic in children. Membranous, its peak incidence in the 4th and 5th decade. In children, if membranous occur in children, usually it is secondary. Membranous caused by hepatitis B. This is the most common cause of membranous in children. Primary membranous, as we said, is the most common cause, never to forget that, is the most common cause of nephrotic in white adults. The most common cause of nephrotic in white adult is membranous. The most common cause of nephrotic in blacks is focal segmental. Our usual image about variations and the causes of nephrotic syndrome. In children, as we said, minimal change is the first one, is the most common one, followed by focal segmental type. In young adult, plaques, focal segmental is the most common one. In older adult, plaques, focal segmental is the most common cause. While in white, here membranous is the most common cause. Either in young adult white population, membranous is the most common cause, or in middle age and elderly white population, membranous is the most common cause of nephrotic. Regarding the pathogenesis of membranous, as we described before, that membranous glomerulonephritis is an immune complex disease. There is antigen-antibody reaction with complement fixation. So there is antigen and antibodies. Antigens identified in membranous glomerulonephritis might be intrinsic antigens in the kidney, or extrinsic antigens. Type, what are the common intrinsic podocyte antigens in the podocytes that are discovered and have a role in membranous glomerulonephritis? The first one is neutral endopeptidase, and we will talk about each one of them. Neutral endopeptidase have a role in antenatal membranous. The most important one, and we will discuss it in details, phospholipase A2 receptor. The most important antigen in membranous. And the more recent one, which have a rule, also a very important rule in membranous, which is the thrombospondin type 1 domain containing 7A. Thrombospondin type 1 domain containing 7A, especially in patients with negative antiphospholipase receptor, have a role, both of them in primary membranous. And also megaline is have been discovered in rats, causing what's called Hayman nephritis. So the identified intrinsic antigens which have a role in the pathogenesis of membranous glomerulonephritis are neutral endopeptidase, have a role in antenatal, and primary membranous, which are very important to us in our practice. The most important is the phospholipase A2 receptors and the thrombospondin type 1 domain containing 7A. And in rats, megaline was identified as an intrinsic podocyte antigen. Here is the antigens, and here are the antibodies to these antigens causing immune complex deposition and immune complexes in the subepithelial surface of the glomerular basement membrane. What about the extrinsic antigens? The extrinsic planted antigens. Extrinsic antigens can be deposited inside the kidney, and then circulating antibodies can make with them immune complexes at that. The most important one as extrinsic antigen was the cationized bovine serum albumin. Cationized bovine serum albumin is the most illustrated antigen as an extrinsic example of antigens which have a role in membranous glomerulonephritis. Now we will discuss each one of these antigens and its role in the management and diagnosis of membranous glomerulonephritis. The most important one is the M-type phospholipase A2 receptor. Again, M-type phospholipase A2 receptor. This is the most important antigen. It is the most important antigen in primary membranous, with the formation of autoantibodies directed against this antigen, phospholipase A2 receptor. Circulating antiphospholipase A2 receptor antibodies against these antigens are detected in the serum of, don't forget this number, 70 to 80% of patients with primary membranous is present in about 70 to 80% of cases of membranous. So what is that? It's sensitivity. The sensitivity of antiphospholipase A2 receptor antibodies to detect primary membranous is 70 to 80%. 70 to 80% is the sensitivity of these antibodies. It is rarely found in secondary. So we are using it to differentiate between primary and secondary membranous glomerulonephritis. Antibodies are mainly of IgG4. This is important. Antibodies are mainly IgG4. These antibodies will react with the antigen and colocalize, forming immune deposits in only primary but not the secondary. Again, these antibodies will be found in primary membranous, not in secondary membranous. The importance of antibodies or antiphospholipase A2 receptor antibodies is that it can differentiate between primary and secondary with a sensitivity of 70 to 80%. Phospholipase, again about our antigen phospholipase A2 receptor, is considered a transmembrane protein of the mannose receptor family. This is the structure of the phospholipase A2 receptor, the M-type phospholipase A2 receptor. It is a transmembrane protein which is divided into multiple domains, started from the cysteine-rich domain, and then the fibronectin-like domain, and then the large one is the C-type lectin-like domain, and then the intracellular domain. So it is formed of multiple domains. What is important for our practice that phospholipase A2 receptor is involved in the production of eicosanoids and reactive oxygen species and DNA damage and cellular senescence. Its role in podocyte is still unknown. This is the site for polymorphism associated with primary membranous. This site this site at the beginning of the C-type lectin-like domain is the site of polymorphism associated with primary membranous type. What are the sites which are identified as epitopes or antigens by the antibodies to phospholipase A2 receptor? These are the sites. These astraxes, sites with astraxes, are the sites which are defined as epitopes by the antibodies to phospholipase A2 receptor. What about thrombospondine type 1 domain containing 7A? A very important another antigen which have a major role in primary membranous. The most important is the phospholipase A2 receptor. And more recently, antibodies to this antigen have been identified to have a role in primary membranous. Again, it is thrombospondine type 1 domain containing 7A. Usually it is identified. It's important that it is positive in patient with anti-phospholipase A2 receptor. In patient with primary membranous, but are negative for antiphospholipase A2 receptor antibodies. We said before that antibodies to phospholipase A2 receptor are present only in 70 to 80% of cases. In these cases, we might find antibodies to thrombospondine type 1 domain. It accounts for 5% of cases of primary membranous. Don't forget this number. يبقى الانتيفوسفوليبase A2 receptor is present in 70 to 80% of primary membranous, and antibodies to thrombospondine type 1 domain are present in 5% of cases of primary membranous in Western countries, and it is much more common in Japanese population. Our next antigen is the neutral endopeptidase, which found to have a role in antenatal membranous nephropathy. It is discovered in a mother which was deficient in neutral endopeptidase. She had been immunized during a previous pregnancy and formed antibodies to neutral endopeptidase, and then in the next pregnancy these antibodies against the neutral endopeptidase bound to the affected child, causing antenatal membranous nephropathy. Usually, anti-neutral endopeptidase antibodies don't account for primary membranous. It might have a role in de novo membranous after renal transplantation, de novo membranous nephropathy after renal transplantation, and in cases of chronic graft versus host disease after allogenic hematopoietic stem cell transplantation. All antigens which we described were intrinsic antigens. Intrinsic, either the phospholipase A2 receptor or the thrombospondine type 1 domain or the neutral endopeptidase. But the example for the blunted antigen or extrinsic antigen is the cationized bovine serum albumin. It usually happens in children, have been described in children with membranous nephropathy who have been exposed to this cationized bovine serum albumin, usually in bottled milk. Usually in bottled milk. This antigen usually localized in the glomerular basement membrane, forming complex with its antibodies. Usually also another example for extrinsic antigen which have been planted in the glomerular basement membrane, usually what happens in secondary cases, especially in lupus, in class 5 lupus and hepatitis B virus associated membranous nephropathy. There is implanted antigens in the glomerular basement membrane which will be co-localized and interact with its antibodies inside the glomerular basement membrane, causing membranous nephropathy. What about causes? Primary membranous, as we described, is usually represent most of the cases. Around 70 to 80% of cases of membranous are primary. And the most important antibody is the antibodies against phospholipase A2 receptor antigens, is present in 70 to 80%. Antithrombospondin type 1 domain usually present in 5%, and the remaining cases will be idiopathic without any identified antigens. What about the secondary causes of membranous? This is very important, very, very important. It might be due to autoimmune diseases. The most important is lupus. And class 5 lupus is membranous. It might be due to other less common causes. These are the common causes, and these are the uncommon causes of membranous. Lupus is very common cause of membranous, secondary membranous. Other remaining autoimmune disease might cause membranous, but to a lesser degree, like rheumatoid arthritis, autoimmune thyroid, IgG4. Infections, also an important cause of membranous. The most important infection and the most common infection causing membranous is hepatitis B. Hepatitis C can cause HIV also. Syphilis might cause membranous. Also malignancy. And the most common cause and the most common glomerulonephritis associated with malignancy is membranous. Never to forget that. The most common GN to be associated with malignancy is membranous. And usually it is associated with solid tumors. We described that in minimal change, it can be associated with Hodgkin lymphoma. But in membranous, it is usually associated with solid tumors, colon cancer, stomach cancer, lung cancer, and prostatic carcinoma. It might be associated to a lesser degree with non-Hodgkin lymphoma, CLL, and melanoma. Drugs can cause membranous, like non-steroidal and mercury, gold, and dipenicillamine. But non-steroidal anti-inflammatory drugs, when they affect, they usually cause minimal change. More than causing membranous. Also, sarcoidosis can cause membranous glomerulonephritis. Alloimmune causes in the form of graft versus host disease after hematopoietic stem cell transplantation. Also, there is de novo membranous nephropathy in renal allograft after transplantation. And as we described before, what happened between mother and her fetus with antibodies against neutral endopeptidase. The most important secondary causes of membranous are very, very important. Lupus, hepatitis B, solid tumors, malignancies, and drugs like gold and penicillamine and mercury. Never to forget them. We cannot identify a patient as primary. We should exclude the presence of secondary causes. If we found patient to have positive antibodies against the phospholipase A2 receptor, usually this patient will be primary membranous. What about the clinical manifestations? 70 to 80% of patients will present by nephrotic. The most common presentation of membranous is nephrotic. It is a classic form. One of the prototypes of nephrotic is membranous. The remaining 20 to 30% will present by subnephrotic proteinuria less than 3.5 grams per day, and the proteinuria is non-selective. The proteinuria in membranous is non-selective. Bardo, it is important to know that microscopic hematuria is present in around 30 to 40%. Don't exclude membranous due to the presence of microscopic hematuria. Microscopic hematuria can occur in membranous in around 30 to 40%, but the RBCs caused are rare to found. In primary membranous, serological tests are very important, as we said. Patients in primary membranous are positive for antiphospholipase A2 receptor antibodies in 75 to 80%. Complement or normal. Very important. Complement is normal. Other serological markers in primary membranous. Markers like الانتي-nuclear antibody, الANCA, CUB, rheumatoid factor are normal or absent. We are talking about primary membranous. So in primary membranous, usually antiphospholipase A2 receptor are present in 75 to 80%. Complement is normal and serological markers are negative. Only in 10 to 20% of cases, patients might have hypertension. Renal function is usually normal. As we said, membranous is a classic presentation of nephrotic syndrome. Only a very, very, very small number of patients might have renal impairment, and it is usually due to dehydration and pre-renal affection. Due to severe hypoalbuminemia, it is usually associated with the diuretic use. Other complications of nephrotic are usually present, including dyslipidemias, and this is important. There is a higher prevalence of thromboembolic events in membranous more than other diseases or other glomerular disease causing nephrotic. The most important or the most common GN to be associated with thromboembolic events is membranous. Don't forget that membranous have a higher incidence to be associated with malignancy, a higher incidence of thromboembolic events. This is very important. To conclude that membranous is rare in children, it is much more common in adult, representing it is considered as the most common cause of nephrotic in white adult, more common in males more than females. As we said, it is much more common in white populations. Nephrotic syndrome is present in 60 to 70%. Blood pressure is usually normal or very mild elevated. Proteinuria is usually non-selective, and there is tendency to thromboembolic diseases. Now we will talk about the pathology in membranous nephropathy. Again, the most important pathological event in membranous, it is an immune complex disease form of IgG and complement. These immune complexes are deposited in the subepithelial surface, along the outer surface of the capillary wall. This will lead to formation of new extracellular material which will be deposited between and around the immune deposits, causing thickening of the glomerular basement membrane and forming what is called spikes. We will talk about it. In light microscopy, in the earliest stages, the glomeruli might appear normal at the very early stage. In the next stage, with more immune complexes are deposited in the GBM, in the glomerular basement membrane, in the subepithelial surface, this will lead to homogeneous thickening of the capillary wall. This is the characteristic sign, homogeneous thickening of the capillary wall, which will be seen in light microscopy. On silver methylamine staining, there will be projections from the glomerular basement membrane between the deposits. There is multiple deposits with more projections getting out from the glomerular basement membrane between these deposits, causing what is called very characteristic, and never to forget, spikes, causing spikes, very characteristic to membranous, a spike-like formation, causing spikes. So later, these deposits will be loosened as these deposits are resorbed, causing these dense deposits to be lucences, areas of lucences. In light microscopy, there is diffuse homogeneous thickening of the capillary wall. On silver stain, we will find the characteristic spike configuration. To help in differentiating membranous from other causes, leukocyte infiltration is absent. There is no leukocyte infiltration, no hypercellularity in membranous. There is only thickening of the basement membrane. يبقى membranous, thickening of the basement membrane, no hypercellularity, no leukocyte infiltration. This will lead to effacement of food processes, and there is no abnormalities in the mesangium again and endothelial cells. The only pathology will be found in the membrane. There is no abnormality in endothelial cells. There is no abnormality in the mesangial cells. There is no hypercellularity. There is only thickening of basement membrane. As we see here, look at the membranes. There is uniform thickening. They are uniformly thickening. Look at here, thickening of the basement membrane. This is characteristic. With no hypercellularity, there is no hypercellularity in the mesangium and endocapillary cells. This is the methenamine silver stain showing the characteristic spike formation. Look at here. There is spikes. What are the spikes? They are projections from the basement membrane, glomerular basement membrane, between the subepithelial deposits. Spikes here, spikes here, more identified spikes. Very characteristic to membranous glomerulonephritis. What about the immune histology? From the pathogenesis, we describe that membranous is immune complex mediated, with the formation of immune complexes between IgG and complement. So there is positive staining for IgG and complement in the glomerular capillary wall in the form of pattern is granular in the form of fine granular pattern, very important. So the pattern, fine granular pattern, positive staining for IgG in the subepithelial deposit with immune fluorescence. The predominant IgG class in primary membranous, this is very important to differentiate between primary and secondary. The predominant is IgG4 subclass 4. But if we found IgG1, 3, IgA, IgM, or other staining, this will guide our diagnosis to secondary membranous, to a secondary causes of membranous. But the predominant immunoglobulin in primary membranous is IgG4, and again the staining is in the form of fine granular subepithelial deposits. Also, there is positive staining for the complement C3 and is usually present in most cases of active disease, and if it is positive, it usually reflects active and ongoing immune deposit formation. C1q staining is not classic for primary. It is usually associated or present in lupus-associated membranous. C1q is not classic for primary. It is usually in lupus-associated membranous. Also, very important to stain for phospholipase A2 receptor that will co-localize with antibodies against the phospholipase A2 receptor, usually in primary but not in secondary. So we might found positive staining for the antiphospholipase A2 receptor, which will differentiate between primary and secondary. So the antibodies can differentiate either in the serum or with staining in the biopsy. We can ask for that. Here we see on the left side the diffuse fine granular pattern for IgG, fine granular pattern like outline the membrane, fine granular, no positive staining in the mesangium, it is in the capillary wall, only in the capillary wall with a pattern of fine granular. This is staining for IgG, and here on the right side it is positive staining also for the phospholipase A2 receptor as we described. Also fine granular pattern in the capillary wall, not on the mesangium. Fine granular affection, fine granular pattern for IgG and phospholipase A2 receptor. In electron microscopy, we will find this characteristic, subepithelial. Again, the characteristics is subepithelial dense deposits formed of the immune complexes of Ig and complement are present in or co-localized in the subepithelial surface. So in primary it is in the subepithelial, but if we found these deposits in subendothelium or mesangial, this will guide us for a secondary cause of membranous. So in primary it is mainly in the subepithelial surface. This will lead to deposition or projections from the basement membrane material between the deposits, forming the characteristic spike formation. Characteristic spike, so we can find it here also in electron microscopy. Later, these immune complexes will be resorbed and it become more lucent. What is important that these changes in the glomerular basement membrane don't correlate with the clinical manifestations or outcome. There is usually food process effacement, and if we found tubular reticular inclusions in the endothelial cells, this is strongly suggestive of lupus associated membranous. Very important if we found them. Tubular reticular inclusions are usually present in lupus associated membranous. This is the capillary lumen, basement membrane, and these are the deposits here in the subepithelial surface with projections between them causing characteristic spike formation. A very important table to differentiate between primary and secondary, very important in our practice and in exams. In immune fluorescence microscopy, the most important and the most dominant immunoglobulin is IgG4. Never to forget, the predominant immunoglobulin in primary membranous is IgG4, while in secondary IgG1 and IgG3. Usually IgA and IgM are absent, but if present usually guide you to secondary cause. Mesangial staining are not present in primary, and if found it will be secondary. C1q, usually it is negative or weak staining, but if it is positive usually it is a secondary cause. The phospholipase A2 receptor positive staining as like in serum, if it is positive staining in biopsy, it is usually a primary membranous, and if it is negative, it is usually a secondary membranous. In electron microscopy, the dense deposits are usually mainly in the subepithelial deposits, but if we found with the subepithelial, if there is subendothelial or mesangial, this is usually a secondary cause for membranous. A very important table and very important differentiating points between primary and secondary membranous. This is our sources. Inshallah, in part 2, we will discuss very importantly the KDIGO 2020 recommendations, and there is a huge modifications in the management and diagnosis and treatment of membranous. We will discuss it in details, inshallah, in part 2 in the near future. Thank you, and Ramadan Kareem.